going to speak on something very difficult because he does lenticules, he does everything, he does, topo-guided treatments, and he's been a pioneer. But I gave him a topic which was very relevant because there are many practitioners who would still want to do microkeratome or femto-guided, femto-Lasik, and we can't be looking down upon them. So they are still a very relevant part. So
Pooja is laughing at me. My topic is over now. Okay, we'll go fast because we have to go. Pooja also has to go to the other hall. I also have to go. So is there a role of microkeratome in today's era? We all have the excimer, and some of us have the lenticule as well as the femto flap procedure. So is there any role? And I think I will answer it fairly. We have gone through a long way. I've been doing Lasik since 1999. I had the I had the microkeratome from Moria, the M2, the M1, the manual, and I've done it all. So is there any advantage? Yes, one choice is availability. Today's world is less. About 10 years back, we had 5 companies making microkeratome, and today only one company has survived, and that's Moria. So you don't have multiple choices of buying multiple microkeratomes, but it's quite affordable. So it's much cheaper than anything else. Very good results with test of time. It is stable, it is consistent. Another big advantage is portable. You can't carry, yes, now the new femto machine can be carried around, which is a Z8, but this one, you can easily carry it around and use it in another Lasik room. It's easy to use. Another big advantage is that the CMC is very less. So CMC is comprehensive contract. You know that if you have an excimer or you have a big femto laser, the CMC is very, very high, so it's a bigger headache. And proven that the test of time, the flap complications are much less today. Yes, you read everything in theory, buttonhole, epithelial ingrowth, stria, etc. It's not that it won't happen, but yes, the incidence with the new microkeratomes is much lower. I agree that there is some incidence of dry eyes, but there is something different, that is a flap to hinge ratio, and there is a learning curve. So this is a blade Lasik, which you can see the microkeratome. You can have a nasal flap, you can have a superior flap, you can have hinge any position you want. So this is the Schwind-Carriazo pendular microkeratome. Just put in a little bit of saline. Once you've done that, go ahead and put on the pendula. Very, very easy to use. I'm making a 90 micron flap. I also have an online pachymeter on the excimer, which will actually tell you what is the flap thickness. And you can see such a smooth bed. I mean, there's no doubt about it. Of course, you have to make sure that you don't keep using the same blade again and again. I normally use one blade for 2 eyes, and that does extremely very well. So this is as far as the this thing is concerned. Again comes to history. So how did laser surgery actually start? It started with surface. There was PRK. Then came blade Lasik. Then came bladeless Lasik. And again, we are back to surface, and then came the lenticule. So this is the evolution that has happened in refractive surgery over the number of years. And studies on dry eyes and healing process has shown that yes, it does heal much faster than surface. Surface does take a little longer to heal compared to the flap Lasik with the microkeratome. And also the confocal photography of the subnormal, the anatomical layer of the stromal fiber arrangement, which is a new technology which Dr. Rohit is actually going to make as a technology or as a machine. And this will help us to understand ectasia much better. So in today's world, we have options like surface, blade, bladeless, flapless, ICL, etc. It's not that you can chuck the microkeratome out. There are big advantages in that. So some centers does only surface in Europe with lenticule. They do not have the microkeratome at all. And some do surface and lenticule only, but no blade at all. And some doctors do everything. It all depends what you can do, but believe you me, it's not that microkeratome does not give results. There are lots of advantages, like you can't do hyperopia in lenticule. You can't do a very high plus with minus on a lenticule. You can't do a wavefront guided or a topo guided lenticule extraction. So these are today's limitation. Of course, it will change over time. So there's also no doubt that surface treatments have improved over the number of years. Now we have something called as a smart pulse. Each one has their own technology where the epithelium itself is removed with the help of the excimer laser. So you don't need to scrape it manually. You don't need to use diluted alcohol anymore. But of course, femto laser is safer, more reproducible. So if you have a small white to white, you would prefer to use a femto. You should not use a microkeratome. 90 micron flaps are today possible. The flap to hinge ratio is one thing which is very, very important, which is very consistent in a femto, but you have to be careful in the microkeratome. What I mean is the diameter of the flap to the length of the hinge is always consistent in the femto, but not consistent in the blade. So that's one care you have to take as far as the blade goes. You can move the hinge in any direction. Side hinge angulation can also be controlled. So lenticule extraction further has changed the game, and of course it comes with a cost, and it's much more expensive. So I'll just show the flap creation on the Z4 which I had before. So this is the flap that is created on the Femto. Now you can see that the diameter of the flap to the hinge length is consistent in each and every case. So this is as smooth as just going underneath and extracting. You can see a very smooth surface. And what I meant was the diameter of the whole flap to the hinge of the length of the hinge is consistent in Femto, not consistent in microkeratome. So that care you have to take if you have a microkeratome. This is just an image of the interface that you can see post-op when you dilate the pupil, and it sees very, very clear. So the answer today, I think there is a room for microkeratome. I don't think we should chuck it completely. Yes, if you have access to a Femto, good. If you can do lenticule, very good. But and you do surface, still better. But it's not that microkeratome should be chucked completely. Thank you for your attention.
Thank you, Dr. Kumar, for very nicely doing that. And yes, there will be always some indications for microkeratome LASIK as well. And also low-cost centers, I've seen that, sometimes in the peripheries where, centers which may not be able to afford a femtosecond laser, the microkeratome will still be very, very economical thing. And also for patients who can't afford surgery of, very expensive refractive surgery, I think we should keep this in the